Welcome to Psych Talk for primary care providers, where our esteemed faculty members will provide you with invaluable insights to seamlessly integrate into your daily practice. Dr. Cameron Quanbeck gives us some valuable information about how to de-escalate agitated patients during this week's episode.
Hi, I'm Cam Quanbeck, a forensic psychiatrist and the medical director of San Mateo County's subacute psychiatric facility. Today we're going to cover de-escalation of the agitated patient. So successful de-escalation occurs in 4 steps. Step 1 is to remain calm, play possum or dead to the bear. It is nearly impossible for a patient to escalate further in the presence of a person who is remaining calm. Introduce yourself, address the patient by their first name, and ask permission to speak with them. Make it clear that you were there to help. Speak in a low tone. Try to use open, relaxed body language. Of course, this is easier said than done. I found that deep breathing before and during the interaction can help. Do your best to ignore their behavior and focus on what the individual is feeling, which is mainly fear. Staying calm will be a stabilizing force for the patient and help them regain a sense of control. Step 2 is to partner rather than argue with the patient who is agitated. Remember that this person is in your ER, hospital, or clinic looking for help. It is our job to help them. That's why we're getting paid. It's not personal, it's professional. So how do we begin to partner with the patient? By asking questions that stimulate rational thought and actively listening with a non-judgmental attitude. Words used in the questions you ask are very important. De-escalation is verbal judo. Avoid closed-ended questions that can only be answered with a yes or no response. The worst one is, can you just calm down? Open-ended, inquisitive questions that can only be answered with a free-form response are the most effective. These are questions that begin with what or how rather than why. How questions seek information rather than why questions. Why questions can make a patient defensive because you are asking them to justify their behavior. So it's, what's going on? How are you doing? Rather than, why are you upset? How questions will get a patient thinking and talking. You may need to ask these questions more than once. Don't be afraid to sound like a broken record. Hey, what's going on? How are you doing? Hey, what's going on? How are you doing? Until they start talking. Hopefully, if things go well, the person will begin to tell you what is making them upset. Actively listen by responding back with one-word agreements. Okay, all right, I hear you, and nod your head. The more severe a trauma a patient is experiencing, the more time should be spent listening. When they're done explaining their situation, pause and reflect back what they've said to you. Okay, so what I heard you say is, reflecting back will let them know that you have listened to them and understand. Step 3 is to express empathy. Say, wow, I can only imagine how difficult this is for you. If I were you, I'd feel the same way. I'm so sorry that you're going through this. There may be a temptation to make it about you. Avoid sharing your own personal traumatic experiences in an attempt to try to reassure them. For example, if you're trying to de-escalate somebody in the emergency room, don't say, I broke my ankle last year and had to go to the ER. I know exactly how you feel right now, you'll be fine. That's going to backfire. You don't know exactly how they feel and what might happen to them. When you're trying to help somebody in a crisis, it's all about them. We're not going to fix their trauma. We can't even imagine how it feels other than it must be horrible. The final step in de-escalation is to give a person options, ideally 3 or 4 different choices. So, hey, you're really upset. Now I understand why. I want to help. Can I get you a drink, a phone, something to eat, or anything else? This process is going to take time, and it will seem to take more time than it actually does. 10 minutes will seem like an hour. There will be time distortion. Asking open-ended questions and giving a patient options will help them move from the emotional mind back into the rational mind. Now, if you notice a patient getting more agitated during this process, never take away the option to leave the situation. If you're not in the room with them, you're not going to get hurt. say, hey, I need a break. I'll be back in 5 minutes. And again, always make sure that you have an escape route. Never put yourself in a room where you can be cornered. Patients set 2 traps for us: you statements and past orientation. The main trigger for the agitated patient that will end in aggression will be talking about you. They will say you, in repetition and try to assign you blame, that you have wronged them in some way. Repeated you statements are a sign that you are in danger. The other trap angry patient will set for us is past orientation. We don't want to get stuck in the quicksand of the past with the patient because the past can't be changed. Agitated patients will focus on, oftentimes, what has already happened to them. If we engage with them in a discussion of the past, we will get trapped in the past with them and feel helpless. So if a patient starts talking about the past, listen initially, but then say, hey, I'm sorry this happened to you, but we can't change that. Let's focus on what we can do now to improve things. In summary, the basic structure of de-escalation is what, how, and let's. It's us together moving ahead. There's no us and them. There is only us, all of us. If you want to learn more about this topic, I highly recommend the book Anger Antidotes by Ian Brennan, who's an expert in de-escalation skills.